Good afternoon. Let me read the first question in our Q&A box. This question is for Dr. Tanya Gosengfiao. Benzodiazepines affect your heart by slowing down the heart rate and blood pressure. What if the patient has heart failure? Would there be possible complications that we should watch for, especially with ICU patients?
Actually, there was a study done outside. This is not for heart failure patients, but just for ordinary patients, where in the Rampart study, it was actually just the people in the ambulance who would give the benzodiazepines at the full dose that was recommended. And they found that there were very, very few side effects, which were mainly hypotension or hypopnea. And in general, it was better really to give the medication. The outcome would be better giving the medication than not giving it. Now, of course, in the ICU, we know that the patients might be a little bit unstable. The blood pressure might be low. I'm supposing that if the blood pressure of your patient is already low from the beginning, baka naka-pressors kayo. And if you're on pressors, then it wouldn't be such a big deal giving the benzodiazepines. Diazepam can cause lowering of the BP. It can cause hypopnea. And so you have to be careful for patients who are in heart failure or who have difficulty breathing. But as I said, since they're in the ICU, it's not so scary because I know that you guys are always there just in case the patient needs to be on pressors or need some supplemental oxygen. But usually at the doses that we give it, they should be okay. In the elderly, I sometimes would reduce the dose.
Thank you. The next question is, if there is no available IV anticonvulsant, how do we give oral anticonvulsant, loading dose and maintenance dose?
I am assuming that this question is for status epilepticus. Really, the recommended for status epilepticus is really IV loading doses because the oral loading doses cannot possibly bring up blood levels fast enough to stop the seizure. And the longer that it takes for you to stop the seizure, the less the chance that you will stop the status epilepticus. In some of the provinces, I realized there are no IV second-line anticonvulsants. However, because we have been going to different municipal health offices and rural health offices, we have training programs for epilepsy manager program. And in those places, they have told us that they do have in their e-cards diazepam IV or midazolam IV. And so sometimes if that's what they have available, then we tell them, sige, you start on the midazolam or the diazepam drip, which can be given third line while you are loading your oral loading, just so you can stop the seizures as fast as possible. Now, for the loading, there was a study in PGH, but I don't know if it was ever published. One of the residents made a study on carbamazepine for loading. And there's no recommendation. There's nothing that says you can load for status epilepticus with oral. But they did a study with carbamazepine oral loading. I don't remember exactly the dose. I think it was something like 5 tablets, so that would be 1,000 milligrams. You just have to tell the patient or the family na malalasing siya or something like that. The problem is that after that study was done, because that was, I think, several years ago, lumabas yung risks for SJS with carbamazepine. Of course, we already knew that there was that risk for SJS, but after that study with the HLAB came out, people were more afraid to use carbamazepine. And so probably if you want to load without worrying as much about the possibility of SJS, you could probably load with levetiracetam. Levetiracetam gives you a very good, it's supposed to be 100% bioavailable through the GI. Usually when you give it, if you give it at the ordinary way, you can reach your blood levels of whatever you start with within 2 days. So probably you could go for loading with 60 milligram per kilogram tablets of levetiracetam. It is relatively safe. There are much less side effects than some of the other medications, but as I said, no studies.
The world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share. Every second counts. Live integrated tele-ultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated tele-ultrasound collaborative platform. Philips Lumify. Integrated tele-ultrasound, powered by React's collaborative platform. Innovation and you, Philips.
And then the third question here in the Q&A box is also for you, Dr. Tanya. Is there such thing as sleep seizure or seizure due to sleep deprivation?
Sleep deprivation is one of the things that can provoke seizures, mainly if you have epilepsy. So if you already have an enduring tendency towards having seizures, then sleep deprivation or flashing lights or when you're extra tired or when you're hypoglycemic, these are the things that can lower your seizure threshold some more and cause your epileptic seizures to come out. There are some people, around 3% of the population, have epileptiform discharges on their EEG, but they don't really have epilepsy. And I'm not sure if those people might be more prone to develop seizures. I have had someone just once na nag-seizure siya kasi hindi siya nakatulog for, I think, 3-4 days, no? With no history of prior epilepsy. We decided not to treat because he didn't want to, and sabi ko sa kanya, just don't get puyat again. And so far, he hasn't come back yet naman. You can have sleep seizures. There is such a thing as nocturnal seizures. So some epilepsies tend to have seizures mainly in the night. So yes, there are seizures that come out more during sleep.